Good afternoon, all. Thank you, man, for that kind words. And let me start with a question. All of you look like a very busy practitioner. So what is the first thing when a patient walks into the consultation cabin you notice or you guess? Age. Yeah, thank you for that answer. So age of the patient is what we would, can I get my slides, please? Can I get my slides, please? Age of, do I press something? Yeah, got it. Thank you. So age of the patient is what we guess. There are some pros and cons of that. You know, when we guess the age, I will dwell into it a little further. So we're going to get in more and more elderly. Our ICMR in DIAB study did show that diabetes is more prevalent in the elderly, and it translates to almost 1 in 5 people, and more older adults are going to walk into your consultation furthermore because it's exponentially increasing. By 2050, you'll have 60 million elderly thanks to the longevity. So what is different when we treat the older adults compared to the regular adults patient type 2 diabetes we treat? Along with all the traditional microvascular and macrovascular complications we deal with, we also have to deal with other emerging complications like the oncological risk, the infection risk is high, MASLD, liver abnormalities are high, functional disability, cognitive disability, and affective disorder. I'll dwell a little bit more on functional disability and cognitive disability. You did tell me, the age is the first thing you will notice when your patient walks in, and most of the time you'll guess, oh, he must be somewhere around 80, or he must be somewhere around 60, and like, oh, damn, he's just 70, or oh, damn, he's 85, You are like, you make a wrong guess at things like that. Why is it so? Most of the contributor is because of their functional ability. So how they walk in, and, the intrinsic functional capacity makes a difference in how we So, and type 2 diabetes and frailty, if you see, have a bidirectional relationship. And so a lot of, pathological processes, cascade of events happen for frailty increasing in the diabetes and diabetes worsening frailty and so on. So frailty rather than the age determines the prognosis for older adults with diabetes. So you have to consider that as your key determinant when you set targets or treatment choices for individualizing the care in our older adults. So we did also look into how prevalent is frailty in our diabetic population at a tertiary center like ours. So it was quite prevalent. We did both with a questionnaire and a hand grip, and we could find that it's quite prevalent all across the group, and it was increasing as age increased. And moving on to cognitive disability in a well-funded economy like US and so on itself, cognitive disability awareness is very poor. So we wanted to look in at our own diabetic population. However, this is the most simplest test you can do for a cognitive assessment in your busy practice. This is a mini cog. It's a 3 steps thanks to our beautiful dietitians who helped us out and take it out in almost 8,826 elicited. And you have a score of less than 3, you consider them as high risk group. And what we found was that 42% of our diabetic population had a high risk score. So most likely they had a cognitive disorder and so on. So we picked it up, and few of the, why is it so? Why is that in diabetic population? This because we all know diabetes per se accelerates aging, and especially brain age or cognitive decline is much more accelerated in diabetes people than in the non-diabetic population due to multiple mechanisms. There can be changes in the white matter microstructure, reduction in gray matter, hippocampal injury, atrophy, and a lot more, which can lead on to a accelerated decline in the cognitive. And many of this could be, you can pick it up at a phase where you can prevent the permanent damage, or an vascular dementia could be picked up early, or an Alzheimer's can be picked up early if you're able to look into the cognitive decline much early in your routine diabetes checkup. So that's what we did. Some of the willing patients got enrolled in our healthy aging clinic, and we could pick up around 32 newly diagnosed mild cognitive impairment. We had around 12 newly diagnosed dementia patients who were on follow-up with our neurologist, and also a few of our depression. So this is a chunk of people who are willing and who we were able to diagnose early about their cognitive decline. And so what are we going to do about it? We do know that there is a functional decline, there is a cognitive decline. So this is a borrowed slide from the Lancet publication. This is the 4S pathway. So how different should we deal with our older adults compared to the other population? So S1 This is a 4-step, S1, S2, S3, and S4. S1 is seeking trigger, so investigate signs and symptoms of factors that may impact treatment goal. S2 is shared decision making, so make sure whenever you deal with an older adult, you have an attender or someone who lives with them. A simple example is during a teleconsultation, I try to put the mode on a speaker mode so that everyone around the house also is able to hear the instruction. Sometimes with the memory, with a lot of things they might miss out. And S3 is to reset goal. So what it means is that even if you've seen the elderly for about 14 times, review patient, yet every visit you consider them as a new patient. And S4 is simple and safer treatment. So simplicity and safety takes over than all your complex regime. So I'll dwell a little bit more on S1 and S4. When does your RADA go up? When should you make changes in your protocol? When the patient is anxious about the medication dose, mixed doses of medication, extra dosing can be dangerous, new or worsening cognitive decline, sleep problem, falls or fractures, cardiovascular event, recurrent UTI, polyuria, urinary incontinence, or harmful weight loss. These are your red flags. So even if the A1C is under control, you have a stable HbA1c, these are your red flags. You have to alter the medication protocol. Talking of HbA1c, the ADA categorizes into healthy, complex, and very complex. So age is just a number. You have to look into the other thing about aging that can make you make a protocol for your population. So 7.5, less than 8, and less than 8.5. This is a busy slide, but a very important slide. So this is about, from our armamentarium, what do we deal in our older adults compared to our younger generation. So if you see here, the top agent most likely associated with tolerability, concern, or treatment distress. Person having a hypoglycemia, definitely assess the regime. So sulfonylureas or glycides, then probably replace with a preferred agent. If she's on a basal insulin, try to change the timing if possible from night to morning. If on a basal bolus, continue the basal but reduce the bolus by almost around 50% and initiate a preferred agent and up-titrate the preferred agent dose based on the glucose level while reducing the bolus insulin dose. And when you achieve the target, stop it, wait for the review, and then alter. It's not necessary to maintain compared to the younger adult. If they are on a split or a mixed insulin dose, use 70% of the total dose as a basal insulin in the morning. If they have a comorbidity like a reduced eGFR and so on, avoid or stop metformin, stop sulfonylurea, do not start SGLT2. That's not the time to start SGLT2 inhibitor. And I think this is very important compared to the ADA ESD guidelines. Here the 4S, they say about the practical things like assess the appetite and the weight of the patient, which I think practically would make a much more, impact on the quality of life rather than, of course, eGFRs, of course, MASLD, all are important, but this is the day-to-day picture. So look at that. If they have a low appetite, low weight, harmful weight loss, then a preferred agent would be a DPP4 inhibitor. And a normal appetite, then a DPP4 GLP. And again, if the eGFR is normal, any of these agents, but preferred will be a DPP4 or tiosinidine, and a preferred in a metformin GLP if there is a normal appetite and there is no concern about weight loss. So I think you get the idea here is that you're focusing more on a simpler and safer regime rather than, try to hit the target hard or keep it under control. So this is the quality of life of these patients do matter a lot, and of course the HbA more than the HbA1c. So there I think you can utilize the newer tools like the CGM and so on, and just not depend only on the A1C for a proper management of these older adults. So moving on, ladies and gentlemen, to the clinical pearls of you're going to see more and more elderly in your clinic hereafter. Consider frailty rather than the age, which determines the prognosis. We also have to be equipped to look at the increasing frailty, cognitive impairment, and other comorbidities which can affect. And not just that, you also look into changes in their living environment, personal circumstances, bereavement in the family, husband, wife are getting older, and insurance change. All these does affect the glycemic control, and we have to look into all of those and de-intensify the hypoglycemia causing medication, reinforce on diabetes management education, not just to the individual but also to the care partner. So as much as possible, let it be a shared decision making. And whenever you're jotting out a treatment plan or a diabetic treatment plan for our diabetic older adult, you have to include functional status, mental health screening, screening for frailty, and a physical examination at every visit. It can vary within 4 months or 6 months in an older adult. And then the lifestyle assessment, medication review, polypharmacy, hearing test, and oncology screening. All of these are very important when you plan treating an older adult with diabetes. So thank you all. Thank you for this opportunity to the organizers. And thank you.